Chitrakala, one thing, can you please tag me on this, the Facebook post?
Sure, ma'am. Sure, ma'am. I will do.
Tag me and Dr. Shady Salim also, please, if possible.
Okay,
Huh?
okay, ma'am.
Yeah.
Ma'am, shall we start?
Yes, please. Yes, please.
Is my screen visible?
Yes, ma'am.
Okay, thank you. So good evening, doctors. I'm Dr. Prachi from Shell Healthcare, and thank you for joining today's webinar. A warm welcome on behalf of Shell Healthcare, and I'm very honored and privileged to welcome and introduce today's guest speaker, Dr. Salim. And Sir is President of Arab Society of Fetal Medicine, Chief Board of New Cleopatra IVF Center, ISUOG mentor, and founder of Arab Fellowship of Fetal Medicine. Sir will be talking on the best regime in patients who are diagnosed with a poor ovarian reserve. And the session will be moderated by our very own Dr. Ritu Santwani. Ma'am is MD, Obs and Gynecology, FICOG, FIAOG, AMR COG, and trained in Singapore for ART. IVF specialist and director of Sham Well Women Clinic in Pune from India. So with this, I request Ma'am to please take over this session. Thank you very much.
Yeah. Thank you so much, Prachi, for the kind introduction. So friends, a very good evening to all of you. Season greetings and a very happy Easter. So I am once again here to welcome you all, and my very dear friend, Dr. Shady Salim here once again. He is a teacher of teachers. I have done so many sessions along with him. As the Prachi has just introduced him, he is the president of Arab Society of Fetal Medicine and the board director of the New Cleopatra IVF Center. So I think let us first start the session. Today's session is on a very important topic, the poor responders and the poor ovarian reserve. So what are the best regimens in the ART? So I think first we will go with the session, and then later on I will ask some questions and I will show what's the Indian data and what the drugs we are using. So over to you, Dr. Shady Salim. Yeah, and many thanks for accepting the invitation. You have to unmute.
Most welcome, Dr. Ritu, and I'm very happy to be with you and with the Shell Connect company.
Yes, you can start the presentation. Yeah.
Okay.
Yeah.
Most welcome, my dear doctors at India. I will talk today about poor responder. What you need to know about poor responder. The infertile patients with aging ovaries, also sometimes referred as primary ovarian insufficiency or premature ovarian failure or poor ovarian responders, constitute a significant bulk of the patient appealing to IVF. The prevalence of this group of patients seems to be increased due to many patients postponing conceptions to late 30s or even beyond the age of 40. In over half of these patients, no etiologic cause can be pinpointed. Whereas depletion of most of the ovarian follicles of the older age of the most ovarian follicles due to the older age is well documented. There are several other etiologies associated with poor ovarian reserve. Among the identified etiologies, different causes have been cited in the literature, including chromosomal, genetic, metabolic, enzymatic, iatrogenic, toxic, and autoimmune and infectious causes. Although the most successful and ultimate treatment of the poor ovarian responder patients is egg donation. The most successful treatment for ovarian poor ovarian responder patients is egg donation. Many, if not most, of these infertile women are reluctant to consent to egg donation upon the initial diagnostic interview, requesting alternative solution despite the low odds for success. Despite being far from cracking the code of successful fertility treatment in poor ovarian responders, many patients feel the need to be convinced that no other solution except egg donation is applicable in their specific case. Only when the alternative solutions prove unsuccessful, as is unfortunately the case in most such attempts, will most poor ovarian responder patients consider and accept the solution of egg donation. This is Bologna city at Italy. What is the definition of poor responder? According to Bologna classification, poor responders defined by presence of two of the following characteristics. The first one, maternal age 40 years or older, or other risk factors for poor ovarian response, such as excision of bilateral ovarian endometriomas. The second criteria is poor ovarian response in previous IVF cycle, retrieval of 3 or fewer oocytes in a conventional stimulation IVF protocol. The third criteria is low antral follicle count, less than 5 to 7 follicles, or low anti-Mullerian hormone below 0.5 to 1.1 nanogram. So we define the poor responder according to Bologna classification if there is two criteria from these three criteria. More recently, a new classification of poor ovarian reserve patients in IVF has been put forward by POSIDON. POSIDON is abbreviation for these statements: patient-oriented strategies encompassing individualized oocyte number. In this classification, 4 subgroups have been suggested according to qualitative and quantitative parameters, like the Bologna criteria, namely age and expected aneuploidy rate, ovarian biomarkers, antral follicle count and AMH. The third one is ovarian response to controlled ovarian stimulation in previous IVF cycle. The first group of POSIDON classification is patients younger than 35 years old with normal markers of ovarian reserve. AMH is more than 0.2 nanogram and antral follicle count more than 5 follicle with unexpected poor ovarian response. This is a normal case. So we don't expect the poor response to ovarian stimulation. This Poseidon group 1 divided into two subgroups. Group A, when we give this patient controlled ovarian stimulation, we only find a 4 oocyte on conventional controlled ovarian stimulation in IVF cycle. The second subgroup in Poseidon group 1 is we only do pickup for 4 to 9 oocyte from this patient. Poseidon group 2, the patient older than 35 years old with normal markers of ovarian reserve, AMH more than 0.2 nanogram, and antral follicle count more than 5 follicles in both ovaries, and with an expected poor ovarian response. We give induction for this case with normal markers, and also we don't expect to be poor ovarian response. And also Poseidon group 2 subdivided into two subgroups. Group A, we retrieve from this patient less than 4 oocyte, and subgroup B, we retrieve from this patient 4 to 9 oocyte. Poseidon group 3, the patient is younger than 35 years old with poor ovarian reserve. AMH is less than 1.2 and antral follicle count less than 5 follicles. The fourth group of Poseidon is patient older than 35 years with poor ovarian reserve. AMH is less than 1.2 and antral follicle count less than 5 follicles. We can conclude this classification in the slide. On the right side, the patient older than 35 years, and on the left side, the patient is younger than 35 years, and the above row, adequate ovarian reserve, and the behind row, the patient with poor ovarian reserve. The Poseidon classification concept offers a possibly improved stratification for poor ovarian responder patients. It presents several possible advantages over previously described models, facilitating the evaluation of strategies that could generate higher success of IVF for specific subgroups of patients. Recently, Alvigi et al. At 2018 have suggested and introduced a new index. This index called Follicle to Oocyte Index, FOI, for poor responders. Whereas poor ovarian responder is characterized by a reduced number of follicles output rate, they suggested follicle to oocyte index as a new parameter to characterize poor ovarian response. The pathophysiologic mechanisms of poor responder are poorly understood. Furthermore, in over half of such cases, there is no explanation. The pathophysiological mechanism put forward to explain poor ovarian responder according to Alvigi et al. At 2018 is associated with polymorphism of the gonadotropins and their receptors. Among the genetic mutations associated with poor responder were LH beta subunit variant, G allele carriers of a common FSH receptor polymorphism, and other mutations of the FSH receptor. In addition to genotypic polymorphism, these investigators mentioned environmental pollutants and oxidative stress as pathophysiologic factors, possibly leading to poor ovarian response. According to IVG et al. At 2018, follicle 2 oocyte index might better reflect the dynamic nature of follicular growth in response to controlled ovarian hyperstimulation compared to traditional markers of ovarian reserve. Antibodies to FSH receptors or to gonadotropins have been also put forward as possible pathophysiologic causes of poor ovarian reserve and poor primary ovarian insufficiency, as well as metabolic causes such as galactosemia. Many poor responder patients insist on multiple attempts to achieve the desired pregnancy using their own eggs. Numerous protocols and medications have been put forward to achieve the gold bullet, which will enable success. This is ancient Egyptian king. What is a possible treatment? Now we know what is the definition of poor responder according to Bologna criteria and according to Poseidon classification, and we try to understand what is the mechanism of the poor responder, and we say the more than 50% of the poor responder patient with unknown mechanism. What is the treatment of poor responder patients? The best treatment for poor responders after a few IVF failure is egg donation. Best treatment is egg donation. Whereas the live birth rate in poor ovarian responder patient ranges from less than 1 to 10% per cycle, the live birth rate after egg donation ranges from 50 to 70%. However, most or almost all patients with poor ovarian responder would persist on multiple attempts to achieve the desired pregnancy using their own egg. Unfortunately, most of the suggested protocols were not more successful than the previously used protocols in this patient. Among these suggested protocols and medications are gonadotropin releasing hormone analogs, androgen, growth hormone, natural cycle or modified natural cycle, high dose gonadotropins, glucocorticoids, coenzyme Q10, acupuncture, holistic medicine, PRP, IV in vitro activation of follicles, combination of the above. Now we can talk in details about each one of these items. Gonadotropin releasing hormone analog. According to Hong et al. At 2018, have recently compared the efficiency of gonadotropin releasing hormone analog versus gonadotropin releasing hormone antagonist protocols in a large number of poor responder patients. They have found a lower cancellation rate, higher implantation rate, and higher low birth rate in young poor ovarian responder patients, Poseidon group 3, but not in the older poor ovarian responder patient, Poseidon group 4. So we can conclude if the patient is from the group Poseidon group 3, we can use the agonist long protocol. But agonist long protocol not efficient in Poseidon group 4. Undergoing the gonadotropin releasing hormone agonist controlled ovarian stimulation protocol than those using antagonist protocol. They concluded that the agonist protocol was more effective than antagonist protocol for young or poor ovarian responder patients. However, other recent studies found no difference in cumulative live birth rate in poor ovarian responder patients according to the Bologna criteria, irrespective of the type of pituitary suppression by gonadotropin releasing hormone agonist or antagonist. So at 2018, we prefer the long protocol than antagonist protocol. But the next year, at 2019, the study found no difference in cumulative live birth rate in poor responder patient according to Bologna criteria. The second item in the possible treatment for poor ovarian responder is androgen. Androgen receptors are expressed in the theca cells, granulosa cells, and ova. Expression of androgen receptors in follicular cells is critical for normal folliculogenesis and ovulation. Therefore, various androgens, mainly testosterone and DHEA, have been clinically tried as co-treatment before and during controlled ovarian stimulation in patients with poor responder, but the success was very limited and equivocal. Whereas androgens may augment the early stages of folliculogenesis, they may be detrimental in supraphysiologic concentrations on the later stages of folliculogenesis, leading to follicular arrest in the sizes of 2 to 9 millimeter, inhibiting deformation of mature Graafian follicle, as it is in PCOS patients. Most recently, a meta-analysis of randomized controlled trial using testosterone co-treatment in poor responder patient found that adding testosterone to controlled ovarian stimulation has significantly increased the number of retrieved oocytes, number of generated embryos, clinical pregnancy rate, and live birth rate in comparison to control. A recent review suggests that testosterone may play a beneficial role in folliculogenesis and may be possibly beneficial in controlled ovarian stimulation for poor responder. However, the evidence from published clinical trials is weak and falls short from drawing robust conclusions regarding the effect of testosterone in poor ovarian response. Since the short administration or high dose of testosterone are not in keeping with the physiologic role of androgens in the ovary and the presence of androgen receptors during folliculogenesis. Many studies examined the effect of dehydroepiandrosterone DHEA supplementation on controlled ovarian stimulation for IVF in patients with poor ovarian response with equivocal results. Several publications reported on improved hormonal levels, higher number of retrieved ova and generated embryo, better fertilization rates, improved embryo quality, lower cycle cancellation, fewer pregnancy loss, miscarriage rate, and higher clinical and cumulative pregnancy rate. On the other hand, other studies didn't find any improvement in the results of controlled ovarian stimulation in poor responder patients co-treated with DHEA. There was no difference in fertilization rate, no increase in the number of generated embryo, no decrease in the pregnancy loss miscarriage rate, no more clinical or ongoing pregnancy rate, and no improvement in live birth rate. So what is the conclusion of use of androgen in poor responder patient? We can conclude that the addition of androgens to controlled ovarian stimulation in poor responder patient doesn't generate a sensational or even a significant improvement in the results of IVF. Again, the conclusion is adding of androgen, especially DHEA, to the controlled ovarian stimulation in poor responder patient don't improve the pregnancy rate or live birth rate. This is also at the Egyptian Museum with Ancient Egyptian. The third one, we talk now about the androgen and long or antagonist protocol. The third one is growth hormone. The addition of growth hormone to gonadotropins in controlled ovarian hyperstimulation may upregulate the intra-ovarian insulin-like growth factor 1 and augment the stimulatory effect of FSH on folliculogenesis. Indeed, others have found that growth hormone co-treatment may augment the folliculogenetic effect of gonadotropins and possibly increase the conception rate. Recently, Colvinder at 2019 declared that the addition of growth hormone to controlled ovarian hyperstimulation of poor responder patient is an attractive option for increasing pregnancy rates in IVF. Indeed, in several patients, this expensive co-treatment in controlled ovarian hyperstimulation might increase pregnancy rate and live birth rate. Unfortunately, not beneficial in all cases of poor ovarian response patients. According to the study of Dakhli et al. 2018, he examined the growth hormone role in prospective randomized controlled trial in a big number of patients according to Bologna criteria. They first had controlled ovarian stimulation with long gonadotropin releasing hormone agonist protocol, and the second controlled ovarian hyperstimulation with growth hormone. Despite an increase in the number of retrieved oocyte, metaphase 2 ova, fertilized oocyte, and transferred embryos, despite that, there is no significant difference was detected in live birth rate. The another double-blind randomized controlled trial for patients with ovarian with poor ovarian response, growth hormone co-treatment didn't improve neither follicular recruitment nor estradiol secretion by mature follicles or the number of retrieved oocytes. The confusion and the equivocal results regarding growth hormone co-treatment in IVF and controlled ovarian hyperstimulation is even greater. Several studies have reported on the greater number of overall and M2 oocyte, higher fertilization rates, and the increased number of overall generated embryos, top quality, and the cryopreserved embryos in growth hormone co-treated cycles. On the other hand, other studies reported no difference in number of overall and metaphase 2 oocyte, no improvement in embryo quality, no difference in clinical pregnancy rates, and no difference in live birth outcome. According to the study of Albo at 2019, have reported a case of 29 years old with growth hormone deficiency, infertile patient who successfully received and delivered a healthy boy on the second IVF cycle after 3 months of growth hormone co-treatment, despite no difference in the number of retrieved ova compared to the previous unsuccessful control IVF cycles without growth hormone. The growth hormone co-treatment improved the eggs and generate embryos quality. Similarly, 3 decades ago, we reported on a pan-hypopituitary patient who failed to conceive on several HMG, HCG controlled ovarian hyperstimulation cycles, and after addition of very small amount of daily growth hormone along HMG, HCG, she successfully conceived and gave birth. Addition of only 4 units of growth hormone per day to HMG in controlled ovarian hyperstimulation brought about a significant diminution in HMG consumption. The patient conceived on the second cycle on combined growth hormone to HMG and HCG co-treatment and delivered at term a healthy neonate. Indeed, the synergistic effect of growth hormone and gonadotropins in achieving conception has been proven in infertile patients with growth hormone deficiency, but not in non-growth hormone deficient poor ovarian response patients. So we can conclude if the patient has a growth hormone deficiency, given this patient a growth hormone will be beneficial for this patient. But if the patient non-growth hormone deficient responder will be not effective for him if given growth hormone. The addition of growth hormone co-treatment for controlled ovarian hyperstimulation of IVF patient is quite expensive. It is therefore logically and scientifically justified to use this potentially effective but expensive co-treatment only in the growth hormone deficient poor responder patients who may clinically benefit from it by improving the pregnancy rate and take-home baby rate. Again, logically and scientifically justified to use these potentially effective but expensive co-treatment only in the growth hormone deficient patients who may clinically benefit from it. How can we identify those growth hormone deficient patients? This is very important question. If I tell you we give growth hormone only for poor responder patients with deficiency in growth hormone, so the next question, how I can detect or how can we identify those growth hormone deficient patients? We can do that by the Clonidine test. Clonidine is one of the commonly used pharmacological agents for growth hormone stimulation. This is a simple test capable of identifying growth hormone deficient patients or those with very low growth hormone reserve. Based on this simple test, it is possible to prospectively identify those poor responder candidates who may benefit from growth hormone co-treatment along controlled ovarian hyperstimulation for IVF. So, co-treatment with growth hormone was associated with a reduction of approximately 30% in gonadotrophin requirement. So, growth hormone may be beneficial and increase the ovarian response and generated pregnancy rate and the live birth rate in only Clonidine negative poor responder, but not in Clonidine positive infertile patients. This is conclusion of given a growth hormone. We only give these expensive medications, growth hormone, only for Clonidine negative poor responder patient. The fourth item in the treatment of poor responder is type of controlled ovarian hyperstimulation. Natural, modified natural cycle, or high dose controlled ovarian hyperstimulation. The Practice Committee of American Society of Reproductive Medicine has recently summarized and compared the pregnancy rate for poor responder in IVF in the natural cycle or with mild controlled ovarian hyperstimulation versus conventional IVF. Similarly, ISHI consensus has defined the Bologna criteria of poor response to controlled ovarian hyperstimulation for IVF according to Bologna criteria, which mentioned before. The results of two randomized controlled trials that compared the mild ovarian stimulation versus standard high dose stimulation IVF in poor responder patients showed comparable clinical pregnancy rate. On the other hand, poor responder patients didn't benefit from high starting dose of gonadotropin in controlled ovarian stimulation for IVF. At the past, we start with the poor responder patient with the maximum dose. The maximum dose is 6 vials, 450. But now, according to this study, we find the use of 300 unit the result is the same. As you see, compared daily fixed dose of 300 international unit of recombinant FSH with 450 international unit or 600 international unit in randomized study, they found no significant difference in any outcome parameter. So, increasing the daily FSH dose beyond 300 units increases the cost burden to the patient without any additional benefit. So please don't give the poor responder patient 450, but please start with the patient with dose of 300. The next item in treatment of poor responder is use of glucocorticoids. In few cases of poor ovarian responder patient, the etiology seems to be an incorrect immune recognition of ovarian self-antigens, such as anti-FSH receptors associated with other autoimmune phenomena and or antibodies against different tissues besides the ovary. The association between autoimmune diseases such as Addison disease and thyroiditis and ovarian failure or ovarian insufficiency and anti-FSH receptors antibodies has been documented. And ovarian failure or ovarian insufficiency may be a part of an autoimmune polyglandular insufficiency, including hypoadrenalism, hypoparathyroidism, and mucocutaneous candidiasis. The possible efficiency of treatments such as glucocorticoids for immunosuppression, gonadotrophin releasing hormone analog, exogenous high dose gonadotropin, and estrogen replacement is unclear, despite suggestion by many do tell case report. Furthermore, the beneficial effect of these treatments and cause-effect relationship has not been demonstrated in prospective randomized controlled trial. Whereas the prevalence of adrenal autoimmunity in general population is approximately 1 to 10,000. It can be found in 2 to 10% of ovarian failure patients or ovarian insufficiency patients. It has been postulated that antibodies against the gonadotropin receptors may play a pathophysiologic role in the mechanism of ovarian response, poor ovarian response patients. Therefore, several investigators used the glucocorticoids and gonadotropin releasing hormone analog together with high dose gonadotropins in an attempt to induce ovulation and achieve pregnancy in poor ovarian response patients. The explanatory rationale to this endeavor was that the inactive high endogenous FSH levels can't induce ovulation due to the possible anti-FSH receptor antibodies blocking their activation. The next item in the treatment of poor responder is use of coenzyme Q10. Where is the causes of poor ovarian responder are unknown in most cases, and since oxidative stress and the mitochondrial dysfunction have been put forward as one of the possible pathophysiological mechanisms, the antioxidant coenzyme Q10 has been tried as a controlled ovarian hyperstimulation co-treatment in such young patients. The coenzyme Q10 antioxidant is a lipid-soluble coenzyme, obligatory structure of the inner mitochondrial membrane. This coenzyme enables for the electron transport in mitochondrial respiration and oxidative phosphorylation necessary for adenosine triphosphate production. Acupuncture, the effect of acupuncture in IVF outcome are equivocal. Holistic medicine The same feeling of anxiety and frustration after poor ovarian reserve and repeated unsuccessful IVF cycles led couples to try holistic medicine as they had with acupuncture. Holistic healthcare considers all therapeutic experiences. It has been suggested that comprehensive medical services are needed in addition to psychological support, counseling, and education. It has been emphasized that all patients' questions should be patiently and thoroughly addressed in order to minimize anxiety and fear and recognize psychological issues that may influence therapy. Unfortunately, sometimes recommendations given by alternative medicine practitioners may contradict or interfere with the instructions given by their IVF physician. BRB. In the last year, a glimpse of new hope for poor ovarian reserve IVF patients has been suggested by two preliminary publications. In these reports, autologous PRP was injected intra-ovary by transvaginal sonographic guidance before IVF controlled ovarian hyperstimulation. The preliminary results suggest a trend toward better implantation rates and live birth rate in those poor ovarian response patients who have received the intra-ovarian BRP injection. Interestingly and encouraging, autologous FSH decreased and AMH increased following the PRP treatment. However, the number of patients used in this publication is insufficient to use this treatment for all patients. So we need more studies in this field of this new hope. In vitro activation of follicles, most recently at 2020, reported on drug-free in vitro activation of follicles for infertility treatment in poor ovarian response patients with the IVA in vitro activation of follicles method suggested a possible infertility treatment for patients with ovarian insufficiency. The IVA in vitro activation of follicles approach promotes growth of residual ovarian follicles following ovarian tissue fragmentation, leading to hyposignaling disruption together with in vitro incubation with follicle activation stimulators. However, the IVA method has been considered equivocal regarding its efficacy and safety, whereas in vitro studies have suggested the activation by a pharmacological method may negatively affect oocyte quality. Conclusion. Also frustrating to both patients and healthcare practitioners, no solid data recommend on any magic bullet protocol for patients with poor ovarian response. The only protocol offering very high success rate is egg donation. There is no treatment for poor ovarian response patient except only protocol offering very high success rate is egg donation. Unfortunately, many, if not most, poor responder patients will undergo numerous unsuccessful IVF attempts before falling back on the recommended egg donation. growth hormone is given only for patient with clonidine negative patient. Growth hormone not effective for all patients with poor ovarian response. Growth hormone is effective only in clonidine negative patients. In poor ovarian response patients with evidence of autoimmunity to various glands and organs like thyroid, adrenal, suggesting an autoimmune pathophysiology to their poor ovarian response, a protocol combining glucocorticoids, long gonadotrophin releasing hormone analog, and the high dose gonadotropins may improve the number of retrieved oocytes and possibly also the IVF results, even in cases where there was a significant increase in the yield of generated ova and embryo by this protocol. The maximum recommended attempts is 3, since all the pregnancies achieved by using this combination were successful within 3 attempts. In addition, the preliminary optimistic report on autologous PRP intraovarian injection and IVA in poor responder patients await validation by future prospective randomized control trials. And finally, many thanks for all my dear candidates and for my dear Dr. Ritu and the Shell Connect company. If there is any question.
Yeah, thank you so much for such a nice presentation. As usual, you always rocks. Please stop sharing your screen.
Okay.
Yeah. Chitra, do we have received any questions on the Facebook?
Yes, ma'am. 2 questions, ma'am.
Okay.
Shall I post a question to you, ma'am, in chat box?
Yeah, no issues. You can post it. Yeah. We are taking some questions.
Okay, send it on chat.
Yeah. Here in the chat box she has posted. Is it visible to you, Dr. Salim? What is the treatment of choice in high FSH and low AMH? Your opinion in using PRP in this condition?
PRP need more study. This is in my conclusion.
Yeah.
Only I tell you, we only give growth hormone for poor responder for patients with deficiency in growth hormone. This first one. The second one is BRB and IVA is need more study, as we don't have a good evidence about use it. So we need more study on a large number of patients to can get an evidence from it.
Agreed.
High
Thank you.
FSH and low AMH, the ideal treatment is egg donation.
Yeah, but all the patients are not ready here for the egg donation also. So yes,
egg donation is prohibited at Islam and at Egypt and all Middle East countries. There is no egg donation.
Okay. So you are using this growth hormone. You're using this growth hormone in your country?
Yes, we use growth hormone for patients with deficiency in growth hormone, not for all patients. Not all patients will be, yes, you, okay. And I have a friend at Venezuela named Dr. Carmen. Dr. Carmen make a study for 2 years about use of PRP in poor responder patients, especially above the 40 years. And she tell me there is a good result with her, but still this is a good doctor. This is level 3 evidence, experienced doctor. Experience of Dr. Carmen is level 3 evidence. So we need more study about BRB.
Correct. Yes, we are also using this intra-ovarian PRP, but yes, definitely there are not much documented studies. Are you talking about this Dr. Carmen from the Lebanon? Is she from Lebanon? Dr. Kariman from Lebanon? Dr. Kariman. Dr. Kariman is from Lebanon. I'm asking you.
Most welcome. At Lebanon, I think it is not prohibited to do egg donation. I think it is possible to do that.
Okay, okay, okay. Can we take the other question, Chitra? If any question, otherwise I will show the Indian statics, what we are using.
Ma'am, as of now, no questions, ma'am. I'm waiting for the questions, ma'am.
Okay, okay. So friends,
The
with
conclusion
us,
of this lecture is there is no treatment for postmortem.
No, wait.
except egg donation. This is the conclusion.
No, I will, yes, of course, but of course, I will show you some PPTs, what we are using here. We are using
Yes,
this
okay.
yes, we are using DHEA and we are using the leucine supplements, which are also giving a very good results. So you are using DHEA? DHEA you are using in your country?
At the past, used by me, the DHEA used by me, but according to evidence, there is no evidence for about effect of DHEA, so I stopped use it. As it is expensive without any cost burden on the patient only.
Okay. Other thing I want to know, in your country, is this IVF is with the support of the government or the patient has to pay their own?
Many companies make herbal and supplement for patient and tell the patient there is will help you to be good and make good ovaries. But according to evidence, there is no evidence.
Okay. So Prachi, can I share my screen, Dr. Prachi? Chitra, have you made me the host?
Yes, ma'am. I think so. Dr. Prachi ma'am's laptop got hanged.
No problem. I am sharing, huh? I am sharing. Yeah.
Okay.
I am showing here some Indian data, what we are using.
Okay, very nice. Tell me your experience.
Yes. Let me tell you, doctor, so many doctors have joined across the globe. What happened? My presentation will start with this because in India, especially in the Pune where I am staying, is again going through a very bad phase of the corona. So as Dr. Salim, you are showing here some Egypt slides. So here means my presentation will start by worshipping of my goddess so that she can protect us from the corona. So I start with these two lines. Sorry, these are in Sanskrit. I will later on send you the translation. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. So first of all, namaste to everyone and salam alaikum to all of my friends who have joined across the globe, especially from the Arab countries. And very warm welcome and thanks for accepting the invitation to dear friend Dr. Salim. We have done so many programs together. So, as I will skip some slides, what he has already covered for this, the poor ovarian reserve. Now, what we are using, what the trials I have done at my center, I am going to share the data about that. So, infertility management, diminished ovarian reserve, and the premature ovarian aging. Friends, those all of you joined are, So, as all us know, this year the Women's Day concept is choose to challenge. So I'm accepting the challenge of Dr. Salim. He's saying no for DHEA and other supplements. Yes, I am accepting the challenge what I have used.
Nice.
So as we all know, the infertile ladies are mostly this coming from in the phase of the depression. So once we make them pregnant, the phase of the joy and happiness. So I will take few of these slides. So, as already mentioned, the diminished ovarian reserve is defined as a decrease in the number of the quality and quantity of oocytes, and the women with DOR at the risk of the poor ovarian response to ovarian stimulation in ART. So here I want to specify over this criteria. The serum FSH, the normally is less than 12 international units per ml, while in poor ovarian reserve, it will come more than 12 international units per ml. Serum AMH normal is 2 to 4 nanogram per ml, and in POR is less than 1, while in AFC is in the normal more than 10, while in POR is less than 5. So this I'm skipping because he has covered very nicely this all. So I don't want to repeat this Bologna criteria. So now in this poor ovarian reserve, what are the factors responsible? Yes, the advanced reproductive age, of course. Yes, here in the metro cities, the smoking, alcohol is of course definitely contributing a lot of that. The family history and the fragile permutation carrier, previous ovarian surgery, especially for the endometrioma or the ovarian cyst, history of chemotherapy or radiation, conditions that cause other surgeries which may are causing the ovarian injury, or the some genetic conditions. So, as we know, the diagnostic parameters for this ovarian reserve is the biological, biochemical, and biophysical. In the biological, as all we know, that biological clock never stops. So, the chronological age. In the biochemical factors, the FSH more than 12 international units per liter, and the AMH less than 0.5 to 0.9 nanogram per ml, while in the biophysical, AFC less than 5. Coming to the next. So, according to this ISHRE guidelines, in accordance with ISHRE consensus, the patients with reduced ovarian reserve should be defined as expected poor responder to ovarian stimulation. So so what are the problems in this DOR and POR? The poor and depleting follicular reserve, mitochondrial dysfunction, reduced blood flow to ovaries, and higher level of free radical damage. So, what is the effect of this on the outcome of pregnancy? Yes, as we know, the decrease in the embryo quality with advancing age, decrease in the spontaneous fecundity with advancing age, decrease in oocyte numbers, decrease in embryo numbers, which in turn decreases the pregnancy rates with infertility treatments. And as we know, the aneuploidy increases with advancing age. So this poor ovarian reserve leads to a poor outcome of pregnancy mainly because of two factors: decreased level of intra-ovarian androgens and the oxidative stress due to reactive oxygen species. So what's the role of this oxidative stress? How it affects the fertility? As we know, the free radicals function in the microenvironments of oocytes and in follicular fluid. Changes in these microenvironments directly impact the follicular development, ovulation, quality of oocytes, sperm and oocyte interaction, implantation, and early embryonic development. And this oxidative species, how it damages the oocyte, as we know. Once this oxidative stress increases, it causes the follicular atresia, apoptosis, by which the number of follicles decreases and the ovarian reserve decreases. Accelerated oocyte aging and decreases the oocyte quality. And here we have seen this reactive oxygen species either by this physical and chemical stimulation or by the aging. It causes the decrease in the mitochondrial activity, which in turn decreases the ATP synthesis. Antioxidant enzyme activity decreases, which in turn increases the chromosomal damage, which in turn causes either the patient may present with infertility, abortion, or the DNA abnormality. So now what are the management options are available? Yes, first and foremost, especially in the metro cities, the lifestyle modification is very, very important. Quitting of the smoking, stop alcohol intake, weight management, and the antioxidants. As Dr. Salim has also taken in his presentation, yes, there are a lot of studies have come regarding the use of melatonin, vitamin C and E supplements, coenzyme Q10 he has already covered, and the role of this DHEA. So this, as I already told, the quitting of the smoking and alcohol is very, very important, especially in the metro cities. So it's like an epidemic, I can say, this smoking and alcohol. So now what we are giving in the adjuvants in the treatment to increase the response and to improve the ovarian mitochondrial function and to improve the blood flow to the ovaries and the free radical quenching. Coming to this one by one. So now what are the studies available? This is a one molecule which is giving a very, very good results. What's the role of the leucine in the management of the poor ovarian reserve patients? So there are a lot of studies. Yeah. Yeah. So there are a lot of studies which have shown the link of the MTOR to several human diseases, including the cancer, neurodegenerative disorders, and aging. Cellular metabolism comprises the foundation of all biological activities, including female reproduction. And the incidents have shown that MTR regulates the processes are important for the folliculogenesis, oocyte meiotic maturation, ovarian somatic cell proliferation, steroidogenesis, ovarian aging, and the embryonic development. So the rapamycin is a macrocyclic lactone which is produced by the bacterium Streptomyces hygroscopicus that was previously used as an antifungal agent but abandoned soon because of its immunosuppressive effect. The protein target of this rapamycin was originally discovered in the genetic mutation studies using Saccharomyces cerevisiae and subsequently found to be the target of the rapamycin FKBP12 complex in the mammalian cells, which is now referred to as the mammalian target of rapamycin mTOR, mammalian target of rapamycin. So a lot of studies have come in the favor of this also. This I have just taken. So the role of this mTOR in the signaling of the folliculogenesis. As we know that during the folliculogenesis, the primordial follicles develop to primary, preantral, antral, and pre-ovulatory stages, and finally able to release an oocyte for fertilization. Primordial follicle activation, which is the beginning of the follicular development after puberty, determines the ovarian reserve and reproductive lifespan, and MTR signaling is involved in these changes. So we can see how it is acting, this leucine on by mTOR. So I'm coming to next, how it is helping in this acetyl coenzyme A and acetoacetate, which in turn helps in the energy production. So there are a lot of studies in the favor of this, that how it is acting and how it will help in the production of the growth factors. So there are a lot of studies. One study has been presented for this mTOR pathway in reproduction from gonadal function to the development coordination by this Korea and Maria in the favor of this. They have shown this mTOR in the oocyte meiotic maturation, and that how it acts in the spindle morphology and chromosomal alignment, and it helps in activating the cytoskeleton, and how it helps in primordial follicle activation. This elevating mTOR in primordial follicle growth cells or the oocytes activates the primordial follicles. Again, the role has been come of mTOR role in the somatic cells, and studies have come for this role of this mTOR for the endometrium. The studies have come that this E2 stimulates mTOR expression to promote the protein and DNA synthesis, but P4 inhibits the DNA synthesis through another pathway. So there are a lot of studies have come. the studies have shown that AMH and AFC both are increased after the use of this. AMH role in recruitment of the primordial follicles. Absence of AMH diminishes the primordial follicle pool. AMH is involved in initial follicle development, and serum AMH level correlates with ovarian follicle number. There is one more study which is presented by this PMC in NCBI journal. We can see on this is published in 2019 only, the role of mTOR signaling in the female reproduction. So in the favor of this only, the studies have shown this mammalian target of rapamycin is conserved serine or threokinase kinase of the phosphatidyl inositol kinase related that regulates the cell growth, metabolism, and autophagy. So extensive studies have been for the favor of this has been presented. So now what the data is of this in with the Indian patients with leucine of the poor ovarian reserve. So the studies have been done. The one study has been done in the Bangalore. There we have there they have noticed the change in the ovarian response and embryo quality after 90 days of L-leucine 800 mg capsules therapy in poor ovarian response patients undergoing the controlled ovarian stimulation. They have seen a very good results after giving up this 90 days of this capsule. Improvement is seen in AFC, AMH, and after giving this stimulation, the total metaphase M2 oocytes have also increased. Yeah. This I am quitting. This study has shown that 800 mg of L-leucine daily could offer hope to PR patients where improvement in ovarian response and embryo quality could offer the better chances of pregnancy. So this we have just discussed. As Dr. Shady has already covered in his slides regarding the use of this DHEA. So the lot of studies, because here in India, yes, we are using extensively this DHEA, but now once this leucine has been launched, the very good results have come with this leucine also mTOR. So I'm just quitting because what the things he has covered, I am not taking all that again repetition. So yeah. We know that mitochondria in the female reproduction plays a very, very important role. The production of energy for the metabolic requirements of the oocyte is provided solely by the mitochondria. And this during the recruitment of the follicles, there is a marked increase in the mitochondrial mass from 6,000 mitochondrial DNA copies to 2 lakhs up to has been reported. So diminished ovarian reserve is associated with reduced mitochondrial DNA count. So we can see this in the normal aged women of 20 to 30, it's more than 3 lakh, while in diminished ovarian is reported to be less than 1 lakh. This study has been supported by the ISHRE, the ovarian aging and the role of the mitochondria in the oocytes and follicles. So Dr. Shady has very extensively covered regarding this coenzyme Q10, that how it acts for the mitochondrial energy production, reduces the cytoplasmic fragmentation, improves oocyte quality, embryo quality, and improves the embryo cleavage and pregnancy outcome. So I'm skipping all these what he has already covered. So here I want to give this one addition of this. Yes, L-citrulline. Lot of studies have come that L-citrulline has been as a precursor of nitric oxide, which improves the vascularization, increases the permeability of follicles, increases blood flow, increases uterine blood flow. It has got the better selection of follicles, better maturation of follicles, better ovarian response, and better pregnancy rates has been reported. So lot of studies, yes, with in the Journal of the Nutrition also, the supplemental citrulline is found to be more effective than arginine in increasing the systemic arginine availability in the mice. There are a lot of studies have come now in the favor of this also. So these studies have concluded that age-related quality decrease in the ovarian reserve, the cellular malfunction caused by the accumulation of reactive oxygen species, compromise antioxidant defense mechanism, deteriorates the oocyte quality by inducing apoptosis. Again, one very important factor is the melatonin. Only these last few slides, what we are using. Yeah, melatonin is the ovarian specific antioxidant, a vital role in improving the antioxidant profile. There are a lot of studies have come now. We are getting a lot of preparations. We are getting some preparations for this ovulation induction of the clomiphene along with this melatonin, or this melatonin is available now over the counter. Most of the Google CV patients, yesterday only I've got 2 patients. The patients already have started the melatonin. Yes, but we have found a very, very good results with this also. Ovarian follicular fluid concentration of melatonin 3 times higher than the serum, which improves the superoxide dismutase and glutathione peroxidase activity, which significantly decreases the biomarker of reactive oxygen species damage. So there are a lot of studies in the favor of this also. As he has already covered regarding this vitamin E and astaxanthin, so there are a lot of studies in the favor of this also. Vitamin E, Dr. Shady has already covered. So yes, the studies have come. The higher levels of vitamin E improves the quality of the oocyte maturation. So there are a lot of studies. Astaxanthin present in the maturation medium reduces the negative effect of heat shock on the developmental competence of the porcine oocytes. So studies have shown, this is quoted from this British Medical Journal only, Reproductive Biology and Endocrinology, that it significantly increases the rate of oocytes that reach the metaphase 2 and decreases the proportion of the apoptotic oocytes. Studies have come regarding the use of vitamin D3 also, that it normalizes the AMH level, normalizes the granulosa cell expression, increases. So a lot of studies in the favor of this D3 also. So overall, we have seen the DHEA, coenzyme Q10, L-citrulline, melatonin, vitamin E, astaxanthin. Yes, the growth hormone, of course, he has covered. Yeah. So thank you to all of you. Thank you for your interest and for your time. So in my opinion, I will conclude with this one line. Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. A famous quote by this Henry Ford. So thank you, friends.
Very, very nice presentation. Many thanks for this nice information.
Yeah. Thank you. Thank you. We can take, I think there are some questions, Doctor. Huh?
I send for you my lecture on Telegram. So anyone want my lecture, you are free to give it.
Great. I want to know, I am having 2 questions from you. Huh? I always ask you so many questions. I want to know that what will be your line of treatment if you won't receive the oocytes in a prior cycle and no embryo developed. Sometimes we give the stimulation, so up to how many cycles, as you told in your lecture, that you are using up to 300 of FSH. So
we use 300 FSH.
Yeah. But for how many cycles? If suppose, okay. Yeah, thank you. Rest, most of the things you have covered. So if there are no more questions, Chitra, is there any questions on the Facebook or YouTube?
No, ma'am.
No questions. Okay. So thank you so much, Dr. Shady, for accepting the invitation. So before I wind up, I have one more question. So what do you like very much in your profession? I always see you are surrounded by so many trainers, so many students surrounded by you. So what do you like most in your profession?
Many thanks for you, my dear doctor.
Okay. So can you wind up, Chitra? Please ask Dr. Prachi.
Hello, ma'am. Yes, am I audible?
Yes, Dr. Prachi. Yeah.
Yes, thank you very much. Thank you, Salim sir. Thank you very much. Excellent talk. Thank you, ma'am. Very nice presentation. And I guess, Chitra, all the questions were posted, right? We have discussed all the questions. So thanks a lot. So really thank you for a beautiful and excellent presentation. So that's it. So we can complete this meeting.
Yeah. Thank you. Bye-bye. Good night.
Good night. Yes.
Bye-bye.